and gentlemen, I am Dwani Karya and I am going to be your host for this eventful evening. It gives me immense pleasure to extend a very warm welcome to one and all on behalf of CIMS Medica to the ninth grand edition of CIMS Healthcare Excellence Awards 2021, where we are going to recognize the excellence in healthcare in a digital way. CIMS Medica is known to create differences, come what may the situation be. And so is our CIMS Healthcare Excellence Awards 2021 in this pandemic. CIMS Medica, ladies and gentlemen, is a global leading provider of drug information, educational content, and marketing services to healthcare professionals, pharmaceutical marketers, and consumers. It publishes leading drug directory, CIMS, IDR, and various scientific journals, Journal of Pediatrics, Obstetrics and Gynecology, Cardiology Today, and Orthopedics Today, among others. It creates and distributes a wide range of healthcare information, including medical drug and information systems, medical journals, customized communications, and patient education in print, electronic, web, broadcast, and live event formats. It is exceptionally well placed to design and organize engaged congresses, conferences, exhibitions, and CME events that advance the exchange of ideas and best practices. Ladies and gentlemen, CIMS Healthcare Excellence Awards 2021 aims to bring together pharma companies, top hospitals, medical practitioners, physicians, medical companies, service providers, medical institutions, and many other stalwarts from across the industry. Ladies and gentlemen, without further ado, moving ahead to our first scientific session, we now invite our esteemed speaker for topic cardiac care during COVID-19. Ladies and gentlemen, please help me in welcoming Dr. Rajneesh Kapoor, cardiologist and director of interventional cardiology at Medanta, the Medicity, Gurgaon. Very warm welcome to you, sir.
Thanks. It's a privilege to be part of this meeting. And I'm sure these deliberations will go a long way in benefiting the audience. And they will all learn and try to imbibe newer things by virtue of which, things can and outcomes can be made better. So I'll stick to my topic, cardiac care in COVID patients or in the COVID era. So, COVID, as we know, is a viral infection. It has really devastated our society for last 1 or 2 years. And so much so that, we really had a very horrible and tough time in hospitals, and the patients who have been harboring this virus, they in their houses, in their families. And as a society, I think it was a tough time for everybody. And we have tried, we have been struggling to contain this patient load, to control this virus infection, but still, there are no real good fruits. We haven't got that, but still we are trying. So in last 1.5 years, both the waves of COVID patients which we had numerous patients presenting to us of COVID. And starting from once it started in March last year in India, and once the hospitals started flooding with COVID patients, we have actually learned a lot, by means of our experience in handling these patients. So initially, the first wave actually was the COVID virus majorly presenting as lung involvement. Now we all know this coronavirus, which causes this COVID disease. It majorly enters through either the nostrils or the mouth, and it actually harbors into the respiratory passages. And through the respiratory passages, it goes into the lungs and start destroying the alveoli and the alveolar membranes. So that is the basic mechanism by which this disease presents. So once this virus infects the lungs, dominantly the presenting feature of the patient mainly is breathing distress. So they start feeling breathing distress, they get fever on and off, and body aches and malaise. So these are the major features of COVID disease. And breathing distress can be of the varying magnitude, ranging from mild breathing distress to moderate to severe breathing distress. So how clinically we know that this is a patient who requires a ICU care, this is a patient who requires a hospital admission, and this is a patient who can be actually quarantined at home itself, and no need of rushing into the hospital. So the basic, simple, very simple test which tells us is the oxygen saturation, which is checked by a very simple device called pulse oximeter. We fix the pulse oximeter on the finger, and that tells us the oxygen saturation levels. Now, broadly, if the oxygen saturation levels are above 90%, above 90 to 93%, then I think there is no need of panic. Patient can be stationed at home and quarantined, uh, and just take care of all the parameters on an ongoing scale. Daily, patient should be checking the oxygen saturations, the pulse rate, and the blood pressure occasionally. So this is the basic, uh, things which a patient wants to do, patient needs to do at home, and then take care of hydration and good diet. And besides all the prescription which has been advised by a COVID specialist, which includes multivitamins, zinc, and other antiviral, Rabiflu or azithromycin or ivermectin things need to be added into the prescription. So patient should stick to that and be at home. So this is a mild case scenario I'm talking. Now coming to a moderate case where now the oxygen saturation is starting to go down below 90%. So if it is between 87 to 90%, this is a moderate case scenario. And these patients may require more help. So they may be rushed to a hospital. At these levels, patient may not require a ICU stay, but yes, patient should be constantly monitored in the room. Constantly monitoring means that they should be constantly on the oxygen saturation monitor and daily fever checks via nurse, and all the prescription again needs to be followed. But at times patient may require a oxygen inhalation support in this moderate variety. And basically we need to see whether patient is further deteriorating or not. So if the patient holds here and no deterioration further, then he can be kept in the room itself and no ICU stay still is required. But yes, here the markers are very important. So what are the investigative markers one needs to do? The CRP markers and the D dimers. So all these markers are extremely important. Now, if the CRP level is raised in such patients and constantly going further high, so that means the disease gravity is increasing. Similarly, the D dimers. And thirdly, the CT scan. Now, CT scan is of high value in such patients of moderate intensity with the COVID disease. So, if the CT scan shows a typical lung parenchymal involvement of certain part of the lung, and there is a scoring system also which scores the CT score out of 25 or 40. Now, if the scoring system initially is 10, hypothetically 10 out of 25, but the next CT we do, the scoring system has further increased to 15 or 18 or 20. That means the disease is progressing and the patient should require ICU stay. But if the patient holds all the parameters and they remain stable, patient is fine in the room itself. So now coming to the grave cases of COVID infection, the grave cases are the saturations are falling less than 85%. Patient constantly requires a high flow oxygen and all the medicines. Now here comes the role of intravenous drugs like remdesivir and uh, the anti-inflammatory drugs tocilizumab. So in grave cases, we need to do it. We need to give all this IV medication to the patient. And yes, First 1 week, no steroids should be given to a patient, but second week onwards, if the patient is having a moderately severe or severe COVID disease, the steroids are definitely indicated to curb the inflammation and to curb and to control the symptoms of the disease from going worse. So this is again very important. Now, this was the normal presentation of a COVID patient. I'm coming to a heart involvement in COVID patient. Now, reason why I mentioned this, COVID patients are practically having a surge of inflammation in the body. So the viral infection is leading to lots of changes in the body where lots of cytokines are released, and these cytokines are also detrimental in many ways. So these cytokines actually can inflict the heart muscle, the myocardium. And once they start doing so, there could be a presentation of heart in the form of myocardial damage or myocarditis, where the heart function can go down, and patient may present as congestive heart failure. So this is one important presentation of COVID patients where they have been presenting with the involvement of myocardium in like congestive heart failure patients. Similarly, now, as we know, up till now, we have perceived quite clearly that COVID infection is a severe degree of inflammation in the body, right? So that inflammation is also driving or leading on to a prothrombotic state. So what does that mean? So that means that COVID inflammation can lead to a lot of thrombus formation in arteries of the body, in the vascular tree, or even the veins. Now, this prothrombotic the stage of COVID can lead to thrombus formation in arteries of heart also, and thereby leading to myocardial infarctions, which we call it as a heart attack. So patients may present as heart attack because of this prothrombotic state of COVID. That's the number two presentation. Thirdly, there are reports that COVID patients may also present as a rhythm disturbance patient. They may have bradycardias or tachyarrhythmias. So what does that mean? That heart rate may go slow or heart rate may go fast than the normal levels. So if the heart rates are slow, that is known as bradycardias, and we need to keep monitoring the rhythm problems of these patients if at all they have. And if they go below 30 heart rate per minute, then obviously they require some support in the form of pacemaker. But if they are okay above 40, between 90, still they are okay. So this is another presentation that COVID patients may present as bradyarrhythmias requiring pacemaker at times. These are the variable presentations of uh, heart involvement in COVID patients. Now, the typical question comes that whether a COVID patient who has been treated well, who has come out of the COVID window after 2 weeks and now he's COVID negative, can these patients also have a heart problem? Do these patients vulnerable to have heart events still? So the answer is yes. So what happens that COVID viral infection has subsided out of the body and patient may become COVID negative, but the dead virus cells are still causing inflammation in the body, and they can lead to variable heart presentations. All these presentations which I have talked about during the COVID, active COVID time, can happen in the post COVID time also. So the 2 months after the subsidence of COVID infection in the body, still the patient remains prothrombotic, still the patient remains highly vulnerable for thrombus formation leading to acute heart attacks or any other events because of thrombus. It's extremely important because of this scenario that all COVID patients should be covered, especially the moderate to severe degree of COVID infection, should be adequately covered by antithrombotics, anticoagulants. So there are many anticoagulants available, and we routinely prescribe either a ecosprin to these patients or the novel oral anticoagulants like rivaroxaban or apixaban to these patients. So these are really indicated and actually can save many lives, which can happen secondarily because of heart attack as a result of COVID. So this is again immensely important that we should not forget that patients should be continuing to take these drugs. Similarly, in my practice, I have seen patients landing with rhythm problems. One patient landed with a syncopal episode where he was having a frequent loss of consciousness and the ECG was showing bradycardias. So that patient required a pacemaker, and after a pacemaker, patient was absolutely fine. So COVID infection actually can manifest as different presentations involving the heart. The heart attacks we have talked of. We have talked about congestive heart failure because of heart dysfunction, and we have talked of rhythm problems at times requiring pacemaker. And we have also talked that these heart attacks can be saved and lots of lives can be saved or salvaged if we give adequate aspirin and anticoagulants to these patients through the COVID time, through the active COVID infection, and also the post-active COVID infection. So these have been really important tips. And I think if somebody is having moderate to severe COVID, they should be in touch with their physician or a cardiologist also to ascertain that they are well covered with all these medications. Now, one more important thing, and then I'll stop. Uh, the very important fact that COVID patients present with breathing distress, and they continue to present with breathing distress even after the subsidence of COVID infection for varied period of 4 to 6 weeks. Now, at times the physician or cardiologist, whosoever is attending the patient, they think that this breathing distress what the patient is having is because of the lung involvement, and they do not point towards, or they do not emphasize towards that it could be because of heart involvement also. Now here a very simple test of heart called echocardiography again is of high importance, because simple echocardiogram can tell us whether this COVID patient is having a detrimental heart issue or a heart dysfunction, and that heart dysfunction may actually be a cause of breathing discomfort of the patient rather than a sequelae of a COVID lung infection. So by simply doing the very simple screening test called echocardiogram, we can pick many cases where because of COVID, the heart disease got triggered, and now there is an ongoing or a progressive heart dysfunction which is leading to the symptoms. In such cases, if we have screened these and picked up this, then a coronary angiography would be pretty handy, and coronary angiography can tell us and save many lives if we treat these patients. So this is how we should handle a COVID patient, particularly from the point of view of involvement of heart in such patients. But in totality, I have discussed a COVID presentation as a dominant lung problem and a dominant heart problem too, or a blend of these problems also. I'm pretty hopeful that this information will make the audience much wiser and to think ahead that how should they treat the patient, and patients will also benefit from this. Thank you.
Thank you so much, sir, for being with us for such an insightful session, and we are truly grateful for your time. Ladies and gentlemen, moving on to our next scientific session, we now invite our respected speaker for topic Low Dose Rivaroxaban, Vascular Protection Beyond Anticoagulation. Please help me in welcoming Dr. Girish B. Navasandi, Director Cath Lab, Senior Interventional Cardiologist, Apollo Hospital, Bangalore. Warm welcome to you, sir.
Good evening, dear friends from medical science community. Today, myself, Dr. Girish Navasandi, Director Cath Lab, Apollo Hospitals, Bangalore. I've been asked to contribute to a discussion on low-dose rivaroxaban, the vascular protection beyond anticoagulation. Today, there's a great need to prevent recurrent cardiovascular events, and that's where this discussion is going to be relevant. The outline of the discussion would be discussing chronic coronary artery disease, then chronic CAD management strategy with antithrombotics, then recommendations and trials in chronic coronary artery disease, then patient profiles to identify right patient group for this type of therapy, and finally we'll discuss the conclusions. Coming to the chronic coronary syndrome, it's a very dynamic process. You will realize that the cardiac risk, which is the death and myocardial infarction, progressively increases irrespective of what you do, because that is the nature of the disease. But it is worse in certain category of patients, which are these: those with higher risks, with insufficiently controlled risk factors, suboptimal lifestyle modifications, and or medical therapy, and large area at risk of myocardial ischemia are the ones which are most vulnerable, and their risk progressively increases in much larger fold than those who have had a low risk prototype, such as those who have optimally controlled risk factors. Then there is a good lifestyle changes, adequate therapy for secondary prevention, example aspirin, statin, AC inhibitors, beta blockers, and appropriate revascularization. Compared to them, those who have high risk have multifold increase in repeat ACS and risk of myocardial infarction and death. That is where is the need for looking beyond just dual antiplatelet therapy. The chronic coronary syndromes, what we would be discussing today, there are 6 most frequently encountered scenarios as per the current guidelines. The first scenario is a chronic coronary syndrome patient with suspected coronary artery disease and stable anginal symptoms and or dyspnea. There is nothing else, very stable. Second set of patients are with new onset of heart failure or LV dysfunction and suspected to be because of coronary artery disease. Third set is asymptomatic and symptomatic patients with stabilized symptoms of less than 1 year after an acute coronary syndrome, or patients with recent revascularization. These are the most vulnerable. Fourth scenario is asymptomatic and symptomatic patients beyond 1 year after initial diagnosis and revascularization. I think a lot of debate will happen on this. And fifth is a patient with angina and suspected vasospastic or microvascular disease, which is another group altogether, and their management is slightly different. And lastly, asymptomatic subjects in whom CAD is detected at a screening, either treadmill or a echocardiogram, ECG, or a CT coronary angiogram. These are 6 types of scenarios that you would be treating for chronic coronary syndromes. Patients with coronary artery disease remain at high risk for ischemic events. You must remember this. The REACH registry, which was done 4-year outcomes, included 64,977 patients who were more than 45 years of age. When you looked at these patients and analyzed them for CV death, myocardial infarction, and stroke, you would realize that over a period of 4 years, those people who only had risk factors, the MACE events, CV death, MI, stroke, was 9.1%. But if they had a symptom of stable atherosclerotic disease, the MACE went up to 12.2. If they had a prior ischemic events of more than 1 year, the MACE events went to 17%, from 9 to 17%, compared to risk factors only. And those who had prior ischemic event of less than 1 year duration, their risk factor was 21%. So what it tells is more risk factors, more symptomatic, and recent history of acute coronary syndrome progressively increase the risk for another event such as CV death, MI, and stroke. And they need much better protection than what is currently being practiced. That is where the current medical vascular protection was discussed, and it is found to be comprising of 4 pillars. The vascular protection therapeutic pillars at this time are 4. The foundation is anyway lifestyle, which is healthy diet, physical activity, exercise, cessation of smoking, weight control, psychosocial support. This is for everybody. And then these are 4 pillars. The first one is most important, lipid lowering. Maximally tolerated statins, and then add ezetimibe. If not achieving the goal, add PCSK9 inhibitors. Next very important thing is blood pressure control. Use the best drugs associated with least risk of future events, that is ACARBs, beta blockers, calcium channel blockers, diuretics, and others. Then blood glucose control, especially with GLP-1 analogs and SGLT2 inhibitors are the cornerstones, and then you have DPP-4 inhibitors, then metformin, thiazolidinedione, sulfonylureas, and insulins. And now the topic of discussion, and the most crucial one, is antithrombotic protection. That is, so far we know that it was either aspirin or dual antiplatelet therapy, with second agent being either clopidogrel, prasugrel, or ticagrelor. Now, looking at the risk progressively increasing in patients, is there a scope for improvement with current antithrombotic regimens? This was just dual antiplatelet. Could we do anything more? That's where we had to determine the antithrombotic treatments in coronary artery disease. What are the determinants? We had to come to a conclusion. First determinant is patient's characteristics. How old is the patient, whether male or female, race, whether Caucasians, Blacks, or Southeast Asians, or history of ischemic or bleeding events are very, very crucial. Second determinant was clinical presentation. Do they have only chronic coronary syndrome, or have they had acute coronary syndrome, either non-ST elevation ACS or an ST elevation ACS? And what are their comorbidities? Most important ones are chronic kidney disease, diabetes, peripheral arterial disease, and heart failure. If any one of them are there, or more than one, it significantly increases the risk of myocardial infarction, stroke, and death. The other determinant is co-medications. Do they need an oral anticoagulation treatment for any other reason, such as atrial fibrillation or an embolic event, or various drug-drug interactions are also important. And then the last determinant is procedural aspects. Have they had a PCA or a CABG or a femoral or radial access, or whether patients are being for an ACS with invasive or a conservative management? All these 5 determinants will decide short-term as well as long-term antithrombotic treatment. You have to look at the choice of drugs, the drug dosing, and the duration of dosing. All 3 are important. Choice of drug, the dose of the drug, and the duration of the treatment. What is the primary goal? Give the maximum protection against ischemia with the least risk of bleed. That should be the goal of this therapy. When you look at the antithrombotics, whether antiplatelet or anticoagulation against arterial thrombosis, it has 2 mechanisms. One directed against the platelet, that is thromboxane A2 or ADP receptors, and the second one directed against the collagen formation, which is either anti-2A or anti-10A drugs such as rivaroxaban, apixaban, and edoxaban. When you look at the antiplatelet therapy in patients with chronic coronary syndromes who are in sinus rhythm, the recommendations are aspirin 75 to 100 milligram with previous history of MI or revascularization, clopidogrel 75 milligram daily as an alternative. Remember, as an alternative to aspirin in those who cannot tolerate aspirin, then clopidogrel 75 milligram, these 2 are class 1 indications. Then clopidogrel 75 milligram daily may be considered in preference to aspirin, that is instead of aspirin, in symptomatic and asymptomatic patients with either peripheral arterial disease or a previous ischemic stroke or a TIA is a class 2B indication, and aspirin 75 to 100 milligram considered in patients without history of MI or revascularization but with definitive evidence of CAD on imaging, CT coronary or something like that. That's class 2B indications. When you look at the other antithrombotic therapy post-angioplasty, we're looking at with chronic coronary syndromes, aspirin 75 to 100 milligram class 1A indication, clopidogrel 75 milligram daily following a revascularization with a PCI, 600 milligram bolus, and maintenance of 75 mg. That is recommended, at least for 6 months, and lesser for 1 to 3 months in those who are at high risk of life-threatening bleeding, what we call HBR or high bleeding risk patients. At least 1 to 3 months, you need dual antiplatelet. Clopidogrel 75 milligram daily following appropriate loading should be considered for 3 months in patients with high risk of life-threatening bleed. That's class 2A. And when you look at the prasugrel or ticagrelor, may be considered at least as initial therapy. We are talking about chronic coronary syndrome, not acute coronary syndrome. So prasugrel and ticagrelor were primarily in acute coronary syndrome, but in chronic coronary syndromes, prasugrel or ticagrelor may be considered at least as initial therapy in specific high-risk situations of elective stenting for non-ACS, especially for suboptimal stent deployment or other procedural characteristics associated with high risk of stent thrombosis, complex left main stem, or a multi-vessel stenting, or if DAPT cannot be used because of aspirin intolerance. In spite of that, look at the latest recommendation for addition of second antithrombotic drug with aspirin. This is in patients with chronic coronary syndrome in sinus rhythm. Adding a second antithrombotic drug to aspirin for long-term secondary prevention should be considered in patients with high risk of ischemic events, but with less risk of bleeding. You remember this, high risk of ischemic event, but less risk of bleeding. You need to add a second antithrombotic drug for a long-term prevention, probably beyond 1 year. Adding a second, that is class 2A indication, with level of evidence being A, multiple trials. Adding a second antithrombotic drug to aspire for long-term secondary prevention may be considered in patients with at least moderately increased risk of ischemic events without high bleeding risk. The bottom line is, if the bleeding risk is not high, then please protect them if they're at higher risk of ischemic events. That's where the novel oral anticoagulation agents, NOAC in combination with antiplatelets in patients with atrial fibrillation, or another indication for oral anticoagulation. In this scenario, it's recommended that peri-procedural aspirin and clopidogrel are administered to patients undergoing a coronary stent implantation. Then in patients who are eligible for a NOAC, it's recommended that a NOAC, either rivaroxaban 20 mg OD, apixaban 5 mg BID, dabigatran 150 mg BID, or rivaroxaban 60 mg OD is used in preference to a vitamin K antagonist in combination with antiplatelet therapy. Remember that. So NOAC is preferred over warfarin or acetron. Rivaroxaban in combination with antiplatelet in patients with atrial fibrillation, or another indication for an oral anticoagulation agent in a post-angioplasty patient with AF, or another indication for oral anticoagulation. When you look at it, when rivaroxaban is used and concerns about high bleeding risk prevails over concerns about stent thrombosis or ischemic stroke, rivaroxaban 15 mg OD should be considered in preference to 20 mg OD for the duration of the concomitant single or dual antiplatelet therapy. So when the risk of bleeding is high, reduce it to 15 mg OD instead of 20. When dabigatran is used, concerns about high bleeding risk prevail over the concerns of stent thrombosis or ischemic stroke. Dabigatran 110 mg BID should be considered for the duration. Both of them are class 2A indications. So now you have two options, whether to continue dual pathway inhibitor, that means one antiplatelet and one anticoagulation such as rivaroxaban, versus two antiplatelets as aspirin, prasugrel, or aspirin, ticagrelor, or aspirin, clopidogrel in patients with chronic coronary syndromes. When you look at it, there are two situations: stable coronary artery disease on aspirin monotherapy, or second group, admission with myocardial infarction and treated with dual antiplatelet therapy. So let's go to the first one. If there's a stable CAD on aspirin monotherapy, and there's a history of multivessel CAD or MI of more than 1 year but less than 20 years, if yes, and then you look for additional risk factors such as any one of them: diabetes, symptomatic peripheral arterial disease, chronic kidney disease, heart failure, or a prior non-lacunar ischemic stroke. If any one of them are there, then use aspirin plus rivaroxaban 2.5 mg BID for a long-term anti-ischemic protection, provided there's a caution. Indication for oral anticoagulation, example atrial fibrillation, or high-risk features for a life-threatening bleeding such as anemia, history of spontaneous major bleed, bleeding diathesis, or thrombocytopenia, or severe liver disease, intracranial vascular abnormality or neoplasm, or extreme old age. In such patients, just keep only one antiplatelet. Don't go for dual pathway inhibition. Otherwise, chronic coronary syndromes, if multivessel disease or MI of more than 1 year, and additional risk factor, any of them, diabetes, PAD, CKD, heart failure, or a non-lacunar infarct, then use aspirin plus rivaroxaban. It offers you more protection. Now let's go to the second scenario. Patient admitted with myocardial infarction and treated with DAPT. They undergo a coronary angiogram and undergo CABG. For the first up to 12 months, you give dual antiplatelet therapy, either with ticagrelor and aspirin, or prasugrel aspirin, or clopidogrel and aspirin. Beyond that, he goes into the same pathway as stable CAD on monotherapy. So he will be put on aspirin plus rivaroxaban 2.5 milligram BID for a long-term protection. But if the patient undergoes an angioplasty for a primary MI and there's either a conservative management or a primary angioplasty done, if they have a multivessel extensive CAD with diabetes, PAD, CKD, or recurrent MI, or very severe multivessel CAD, look at whether the patient can tolerate ticagrelor. If patient can tolerate, complete that dual antiplatelet for 12 months, and then beyond that, consider aspirin and rivaroxaban. If the patient cannot tolerate ticagrelor, and if there's a history of ischemic stroke, then again go back to aspirin, rivaroxaban beyond 12 months. And if there is no history of ischemic stroke, then prolonged DAPT is better with aspirin and ticagrelor down titrated to 60 milligram BID instead of 90 milligram from 1 year post-MI up to about 36 months. That means to say, who have multiple risk factors, who cannot tolerate ticagrelor beyond 12 months, I think you need to switch them to aspirin and rivaroxaban. But if there's multiple stents or a high coronary burden, then you can continue them on aspirin plus ticagrelor 60 milligram BID even beyond 12 months. That is the discussion and the guidelines. The new guidelines recommend 4 options for dual antithrombotic therapy. The first option is, anyway, you're giving aspirin. Along with that, you can give clopidogrel 75 milligram post-MI in patients who have tolerated DAPT for 1 year. You can give second option as prasugrel 10 milligram OD beyond the 1 year. Post-PCF for MI in patients who have tolerated DAPT for 1 year, provided they are not older than 75 years, try and avoid prasugrel. Third option is rivaroxaban 2.5 milligram BID. If there is a post-myocardial infarction of more than 1 year or multivessel coronary artery disease, then you use rivaroxaban 2.5 milligram BID along with aspirin 75, provided there is creatinine clearance is more than 15 and at least 15 to 30. And ticagrelor 60 milligram BID also can be added to aspirin post-MI in patients who have tolerated DAPT for 1 year. These are the 4 options. We can use either clopidogrel, prasugrel, rivaroxaban, or ticagrelor in those patients who have high ischemic risk and low risk of bleed beyond 12 months. But when you look at the dual pathway inhibition, this targets both platelet activation and persistent thrombin generation in chronic coronary artery disease situation. It does not act only on one platelet mechanism, but on dual mechanism. It acts both on thrombin generation as well as platelet activation. In the acute phase, which is about 1 to 12 months, prevention strategy is always dual antiplatelets. So primarily you focus on the platelet, and platelet activation is strongest in the acute phase. Beyond the acute phase, the prolonged thrombin generation also plays a much larger role. Hence, in the chronic phase, prevention strategy should be single antiplatelet or dual pathway inhibition with aspirin and a NOAC. So now we had multiple trials showing antithrombotics for secondary prevention, that is beyond 12 months, trial-based comparisons when you look at it. In the CAPRI, where clopidogrel was used, then you had a Charisma where you used clopidogrel plus aspirin. And in Pegasus, we used ticagrelor 90 milligram plus aspirin, and Pegasus 60 ticagrelor 60 plus aspirin trial, and then the Compass, rivaroxaban 2.5 and apixaban. When you look at all these, look at the MACE reduction. With clopidogrel, MACE is reduced by 7 to 9%. With ticagrelor, it is reduced by about 15 to 16%. But with rivaroxaban and aspirin combination in Compass, it was reduced by 24%. Highest reduction in MACE was with rivaroxaban and aspirin compared to any of these combinations. More than that, look at the cardiovascular death reduction. With clopidogrel, it's only about 8%. Actually, when you combine clopidogrel and aspirin, death actually increases by 4%. But when you look at the Pegasus, the death reduction is about, CV death reduction is about 13 to 17%, and with rivaroxaban aspirin, reduction is 22% in cardiovascular death. But most astounding is in the reduction of stroke. With the clopidogrel aspirin, there is 21% reduction in stroke. With ticagrelor aspirin, there is 18 to 25% reduction. But look at with rivaroxaban aspirin, 42% reduction in stroke, tremendous. And then myocardial infarction, with clopidogrel as the second agent, 6% reduction. With ticagrelor, 16 to 19% reduction. With Compass, it's about 14% reduction. That is why, if you think coronary myocardial infarction is the primary thing you want to reduce, then I think ticagrelor aspirin should be the choice beyond the 12 months. In all other situations, I think the rivaroxaban aspirin is much superior. And when you look at the major bleeds, when you use only clopidogrel, there's 27% reduction in the bleeds compared to aspirin and anything else. But when you combine aspirin and clopidogrel, there's about 60% increase in the bleed. Ticagrelor aspirin, the increase in the bleed is between 132% to 160%. But with Compass, rivaroxaban and aspirin, the modified ISPH bleeding was increased by about 70%. Here, the goals are much stringent. Any visit to emergency room was taken as a major modified ISTH bleeding risk. The Compass is the only antithrombotic regimen where they used rivaroxaban 2.5 milligram versus with aspirin, showing significant reduction in all-cause mortality, not only cardiovascular. And now a body of evidence supports the use of rivaroxaban 2.5 milligram BID. In the Atlas ACS STIMI trial, you can see that the dose escalation study leading to selection of 2.5 milligram and 5 milligram BID, and then the Atlas ACS STIMI, addition of rivaroxaban 2.5 milligram BID to DAPT significantly reduces CV risk. And in the Pioneer AFPCI trial, the less bleeding with rivaroxaban 2.5 milligram BID plus DAPT versus vitamin K plus DAPT was noticed. And in Compass, in Gemini ACS, 3,037 patients with ACS, rivaroxaban plus clopidogrel is as safe as DAPT in patients with ACS. So those who cannot tolerate clopidogrel or second antiplatelet, aspirin. Then in Compass, we realized that in stable CV disease, rivaroxaban 2.5 milligram BID reduces MACE and major adverse limb events and all-cause mortality better than single antiplatelet agent or with others. In the Voyager peripheral arterial disease trial, this will expand the evidence base to include acute symptomatic peripheral arterial disease. Coming to the Compass trial, which is a landmark and changed the practices, the cardiovascular outcomes for people using anticoagulation strategies, not just antiplatelet. Here it was a randomized, placebo-controlled, double-blinded trial involving 27,325 patients with stable coronary artery disease or a peripheral arterial disease. The run-in period with only aspirin, and then there were three arms. One is rivaroxaban 2.5 milligram BID plus aspirin 100 milligram arm. Second one, rivaroxaban 5 milligram BID alone. And third, aspirin 100 milligram alone. So this was managed over 1.9 years. And Compass is the first NOAC and antiplatelet combination, that is rivaroxaban and aspirin, trial to demonstrate significant reduction in MACE in patients with stable atherosclerotic disease. In this, the patient profile, when you looked at the based upon Compass inclusion criteria, very, very important. Who are the patients who were included? Criteria for coronary artery disease meant previous MI within the last 20 years or multivessel coronary artery disease with symptoms or with history of stable or unstable angina, or multivessel PCI or a multivessel CABG. They were called CAD patients, not garden variety, non-MI patients were not included. But patients with CAD must meet at least one of the following additional criteria, that is age more than 65 years, or if the age is less than 65 years, they had to have plus atherosclerosis in 2 or more vascular beds or 2 or more additional risk factors such as current smoking, diabetes, EGFR less than 60 but more than 15, heart failure, non-lactating ischemic stroke or more than 1 month. Only then they qualified to be part of it. When you look at the peripheral arterial disease patient, they had to have a previous revascularization, previous limb or foot amputation for the arterial vascular disease, and history of intermittent claudication, and 1 or more of the following along with claudication, that is ankle arm BP ratio of less than 0.90, significant peripheral arterial stenosis of more or equal to 50%, documented angiography or duplex ultrasound, or previous carotid revascularization or asymptomatic stenosis of more than or equal to 50%, and then they should have had a coronary artery disease plus low ankle brachial index of less than 0.9. Only then they qualified. And COMPAS enrolled over 24,000 patients with advanced or chronic CAD. You can see here prior MI, 69 patients, multivessel disease, 62 patients, prior PCI in 60%, prior CABG in 32%, and patients immediate post CABG were also there, 6%. CAD, PAD 20%, previous MI 69%, renal impairment 22%, diabetes in 37% of the patient, heart failure 20%. It's a real world scenario when you look at all our practices. So it had a real good combination of real world situation. And the main outcomes when you looked at it, when you use rivaroxaban 2.5 milligram BID plus aspirin versus aspirin alone, the rivaroxaban and aspirin led to 24% reduction in MACE events, 20% net clinical benefit, 18% reduction in mortality. But there was no benefit for rivaroxaban 5 milligram BD alone. Only when it was combined with aspirin it showed that with 2.5 milligram. Rivaroxaban vascular dose plus aspirin reduced ischemic events. CAD sub-analysis, when you looked at reduction in the risk with rivaroxaban 2.5 milligram BID plus aspirin led to 24% reduction in MACE, that is overall MACE. When you look at only CAD sub-analysis, 26% reduction in the MACE, 44% reduction in stroke, CV death was reduced by 25%, and all-cause death, 23%. All-cause death, not just CV. Clear net clinical benefit of 20%. And when you look at the rivaroxaban plus aspirin combination, the MACE events in diabetic and non-diabetic, when you look at it, for the MACE events were reduced by about 28% in diabetic, and non-diabetic it was reduced by 23%. So in diabetic it reduced more. When you look at the ICM, major bleeding was increased by about 65% in diabetic and 67% in non-diabetic, not a great difference. When you look at the selected outcomes from COMPAS trial, whether patient received rivaroxaban 2.5 milligram BID aspirin or 5 milligram BID aspirin alone, when you look at it, the rivaroxaban plus aspirin significantly reduced all events, CV death, stroke or MI, or ischemic stroke MI, acute limb ischemia or CHD death, or ischemic stroke MI, acute limb ischemia or CV stroke, or stroke alone and major bleeding, all of them. So clinical implication of COMPAS, when you look at it, switching from dual antiplatelet therapy to dual pathway therapy, that is rivaroxaban plus aspirin, is the way to go forward in those patients. Therapeutic use and clinical benefits of dual pathway therapy in both coronary artery disease and peripheral arterial disease patients, and dual pathway therapy in PAD from its initiation after the lower extremity intervention and continuing through long-term intervention greatly helps. The 2019 NICE guidelines said that rivaroxaban plus aspirin is recommended as an option for preventing atherothrombotic events in adults with coronary artery disease or symptomatic peripheral arterial disease, or who are at high risk of ischemic events. And the recent US FDA approved indication is CAD or PAD 2.5 milligram orally twice daily of rivaroxaban with or without food in combination with aspirin between 75 to 100 milligram. Coming to the conclusions, patients with CAD remain at high risk for ischemic events. COMPAS study results provide support for the use of dual pathway therapy, that is aspirin plus 2.5 milligrams twice daily of rivaroxaban in stable patients with history of MI, PAD, or multiple risk factors. As per recommendations, dual pathway therapy may be considered for preventing antithrombotic events in adults with CAD or symptomatic PAD, who are at high risk of ischemic events. And it seems to be time to switch from dual antiplatelet therapy to dual pathway therapy, that is rivaroxaban plus aspirin, in patients with chronic CAD who are at high risk of ischemic events but low risk of bleed. Thank you, dear friends. It was a wonderful interacting with you.
Thank you so much, Dr. Girish, for such an interesting session, for sharing valuable insights with us. And thank you for your time. Ladies and gentlemen, moving on to our next very interesting segment, which is the panel discussion. And the topic of the panel discussion is resilience of healthcare in the current scenario. We have here with us our moderator, Dr. Ashwini Jogare, Med Superintendent, Nanavati Max Super Speciality Hospital. She's member of ICC Healthcare Community and a training coordinator at AHPI. Warm welcome to you, Dr. Ashwini. I hand it over to you.
Thank you for the lovely introduction. Now it's my privilege to introduce our esteemed panelist, Dr. Sanjay Oak. We all know Sir. Sir is a pediatric surgeon. We need not describe his credentials, but just for the knowledge of everyone. His MS, MCH, DNB, FRCS, Edinburgh, and Fellow in Royal College of Surgeons of Edinburgh, Fellow International College of Surgeons. Presently, Sir is Director at Kaushalya Abhinav Hospital, and we all know in April 2020, Sir was appointed as Corona Task Force Chief. Sir, Dr. Oak is the former Dean of KM Hospital and Nair Hospital, former Vice Chancellor of DY Patil Hospital. Look at the enormous awards Dr. Oak has received. Just to name a few, Sir has received Dr. B.C. Roy National Award for Medical Excellence in Development of a Super Specialty Hospital, Hariom Ashram Prerit Rangchari Award for Original Research, Dr. Babasaheb Ambedkar Award for Social Contributions, and many more. Welcome, Sir. It's a privilege to introduce Dr. Deepak Patkar, who is a radiologist. Sir is MD, DMRD, DMRE, FICR. Sir was immediate past president of IRI 2020, Director Medical Services here, and also heads the Department of Imaging at Nanavati Max Super Specialty Hospital. Almost near 33 years experience in the field of radiology with all facilities available. Sir, as I mentioned, was a past chairman of Indian College of Radiology and Imaging, member of National Steering Committee for Indigenous MRI, headed by IIT Mumbai. This is a very important project which also connects with the resilience in healthcare. Sir is Chairman Scientific Committee Ocean Congress of Radiology 2018, has received enormous awards in his entire career. Welcome, sir. It's a privilege to introduce Dr. Abdul Ansari, who is Director of Critical Care Services at Nanavati Max Super Specialty Hospital. His areas of core interest is in clinical care nephrology. 20 years of experience in critical care. He has been a teacher and guide for diploma and fellowships programs in critical care. Faculty in national conferences and regional seminars in extracorporeal therapies and sepsis. He has been involved in various clinical trials, especially in this pandemic. Friends, with this, we all know we were eagerly waiting for this important topic of resilience of healthcare in current scenario. This topic indeed is self-explanatory. We all know medicine has come a long way, has evolved along since ancient times. We have come a long way. Presently, we are being able to handle all communicable and non-communicable diseases. Today, we are in the era of robotics, gene therapy. Telemedicine has aided healthcare globally in bringing treatment to the touch of a fingertip. Mankind has dedicated its best minds to aid health and longevity and providing excellent quality of life. We would now move on to the panel discussion, and now none other than Dr. Sanjay Oak. We would like to proceed with the first question to Oak, sir.
It's a privilege to interact with our very own Dr. Sanjay Oak, sir. Sir, we are all eager to hear. We would like to know, with the emergence of first few cases of COVID, we were really perplexed with very little knowledge and direction to move in. It was in a time like this where you played a pivotal role in setting guidelines and policies. As a chairman of COVID task force in Maharashtra, how, according to you, has the healthcare system evolved in tackling the first and the second wave, sir?
Health system has evolved and it is still in evolution. You're right that when it first struck us sometime around last April, it was an unknown enemy. We had hardly heard of this, hardly seen, except the initial cases that were reported from China, Britain, Italy, Singapore, and the various mechanisms by which various countries were trying to combat this virus. We knew for sure that we are in for a big trouble. And that was because of the infectivity. Now, let me split the answer into phase 1 and the phase 2 that we have seen. The phase 1 was a conventional COVID. The newer serotypes had not evolved. But we had to prepare a lot. In terms of public education, continuing medical education with the doctors, increasing the number of beds in the hospital, increasing the facilities of ICU for respiratory cases, increasing the number of ventilators, introducing the concept of high flow nasal cannula and its practical use in these cases. And then there was a big debate about hydroxychloroquine, ivermectin, and various other sister pathies were also claiming miraculous magical drugs. However, in the month of May, we realized the significance of cytokine storm and the way it hits the patients in second week onwards, and realize that it is really speaking not the virus, but what follows because of that in the body, and more so in high-risk factor cases such as diabetes, obesity, hypertension, hyperthyroidism, hypothyroidism, and various other endocrinal issues that makes them more prone for a more virulent cytokine storm, which at times has taken toll. So the whole first phase was oriented towards this and the acquisition of tocilizumab, then the remdesivir, then the role that was played by steroids. And two important things from community perspective. One was use of pulse oximeter as a screening modality in the slums, in the unorganized sectors, as well as in societies, to identify the high-risk individuals. And the second important concept was construction of field hospitals, at least in the metropolitan cities. So I think we worked fairly well. How the task force used to function. The task force is an advisory body of about 11 intellectuals from various hospitals of public as well as private sector who meet every Monday. Right, up till now, we have done about 68, 69 meetings, all virtual. And we take a cognizance of every word that is being printed in scientific journals, mainly New England Journal of Medicine, British medical journals, science, and various other things that come across, infectious diseases journals, epidemiology, and then pick up the things that are suitable to our population and that can be exhibited, that can be executed in our country. So that is how we function. What happened after first wave was probably there was little laxity. The number of tests went down because testing, tracking, and treating, these three T were important. Masking went for a toss. Social behavior became reckless. There were social, religious, and political conglomerations in large numbers. and that hit us in the second wave. More so in the second wave, the virus was evolving with its variants. So we had a British variant, we had a South African variant, we had an Indian variant, we had now Delta, and as you read today, we have Delta plus. But that's expected. With every virus, it evolves. So the second wave had high infectivity and a high virulence. Plus, the age of affection had dropped down by about 10 years. So we saw more and more younger individuals in their 30s and 40s coming and suddenly dying. Myocardiopathies coming up, myocarditis setting up, and various other things happen. So the difference in the first and the second was, if in first out of a family of 6, if one person was getting affected, in the second wave, the entire 6 people's family was getting affected. But now, as the second wave is dying down slowly, though it has a very thick tail, we have all the conventional drugs, plus we have antivirals, we have monoclonal antibodies, and we have vaccination at disposal. Nonetheless, the third wave may come. It's very difficult to predict when it will come. But reckless behavior and slow-paced vaccination is something that I'm afraid of, and that should not happen.
So Dr. Patkar sir, you have played an instrumental role in battling the COVID crisis during your tenure of IRIA president last year. We have witnessed you. So what role has radiology played in helping combat this pandemic, not only in metros, but in tier 2 and tier 3 cities, since not everywhere the RT-PCR was accessible? So we would like to hear as from the radiologist point of view.
Thank you, Dr. Ashwini, for asking this question. Radiologists have been at the forefront of this pandemic right from the beginning. Initially, X-rays were thought to be very, very important for monitoring and follow-up of patients suffering from COVID. If you know, in the month of March, April, when the pandemic started, there were very, very few metros and cities which had RT-PCR, whereas X-rays were available across our country. So a lot of AI work and detection of COVID at many places was heavily dependent on X-ray chest. Problem with X-ray chest was, although it was a very important investigation, sensitivity of X-ray was very, very low. In the initial stage, it was as low as 30%. And after a week, it was about 60-65%. If RT-PCR was not available, a lot of people realized that CT could be a very good option because it had sensitivity of almost 96% after 6 days and about 60% after 3 days of initiation of symptoms. In the first wave, we learned a lot as to how CT can be useful. 1, for detection, 2, for understanding the severity of disease, 3, for follow-up, and also to look at cytokine storm, superadded infections, etc. As you know, in the best centers, the RT-PCR test has sensitivity of about 70%. With RAT, it even comes down further. Whereas sensitivity, as I said, of CT is above 90% within first week and 97% after that, according to several meta-analysis studies conducted across the globe. This stresses on the importance of CT scan. In cases of false negative RT-PCR test, when patient has symptoms, a lot of us, including our own Nanavati Max Super Specialty Hospital, depended on detection of COVID on CT scan and then putting these patients in isolation. This helped us in reducing the spread of infection quite significantly. Other important point that I want to stress on is the TAT. Typically, RT-PCR takes anything between 12 hours to 48 hours to get the result. whereas CT, with or without using artificial intelligence, the diagnosis can be made in a matter of few minutes. Till now, we at Nanavati Max Super Specialty Hospital have conducted more than 4,000 COVID positive and COVID suspect HRCTs with very, very high sensitivity and specificity. The second wave brought with it a few new, more complications that we are aware of. The commonest one being mucormycosis. Radiology in this situation is also proving to be extremely useful in detecting extent and diagnosis of mucormycosis, whether it is limited to PNS or whether it has gone in orbits, skull base, brain, etc. Both CT and MRI of PNS with or without contrast are considered as gold standard and standard of care investigation for patients suspected to have mucormycosis. The traded black fungus, as we call, is capable of making a lot of damage to orbits, brain, etc. And MRI is capable of diagnosing and giving clear extent of the spread of disease to the ENT and ophthalmic surgeons, as well as skull-based surgeons and neurosurgeons. Surgical treatment for mucormycosis is also assisted by radiological diagnosis. Thank you.
Yes, sir. So we also know you play a dual role of medical administrator. So as Director of Medical Services, we are sure you have faced a lot of challenges, and as usual, every administrator has to do. So we would just like to share, if you could share some groundbreaking bottlenecks that you could tackle, not only during the first wave, but I think even second wave was difficult as an administrator. So if you could enlighten us, since many of the hospital administrators have also joined as viewers, sir.
Sure, you are absolutely on that dot. The first wave of pandemic, we started in March 2020, brought with it a lot of uncertainties, and we were all struggling, not only our hospital, but all the hospitals were struggling to survive with lockdown in place. We have an OPD of about 800 to 1,000 patients coming into our OPDs every day pre-COVID time. It dropped to 50 and 60 when the lockdown started. All of us struggled to bring back these numbers because everybody was scared of visiting a COVID hospital, as it was called. Other problem that we faced was lack of availability of beds. Everybody who suspected to have COVID, even before they got their result in the first wave, rushed to the hospital, whether they had symptoms or no. The protocols set in by government and our own hospital were ever changing based on what we were learning quickly from across the world, as well as within our chain of hospitals. There was no vaccine available. There was no clear protocol about isolation of patients as well as staff. Creating infrastructure for staff, doctors, nurses was a big challenge. There was no clarity on what would be the ideal treatment in the first wave. But we managed to swim through and got back on our feet. As soon as we started getting back our numbers, the second wave hit us when we thought we were better prepared than the first time. However, each calamity comes with a new set of issues. As John Wilkinson said, new problems need new solutions, and we have to be really nimble-footed to find new solutions for our new problems. We were providing vaccination, we were providing treatment to patients infected with COVID simultaneously. Our routine work was getting hampered, although it was not as bad as in the first wave. The other problem that we faced was sheer numbers that the city of Bombay was hit by. Initially, for the first wave, we were prepared for 150 beds. Next phase, we prepared for 190 beds. While there was shortage of beds in the first wave, the second wave came not only with shortage of beds, but it came with shortage of medicine like remdesivir and oxygen that was creating havoc amongst patients and public at large. Another major problem was the rise of black fungus or mucormycosis and the problems it came with. There was paucity of amphotericin B. There was paucity of oxygen. Fortunately, at our hospital, we never had to face shortage of medicines at any point of time. A separate ward is created now for mucormycosis patients to avoid cross-contamination. We managed to keep our supplies adequate by a very well organized central supply and coordination with the government. Availability of oxygen, as we all know, was a major hurdle in several states, but at our hospital, we managed to provide oxygen adequately. We had increased our capacity in the first phase, in the first wave itself, and that really helped us to pass through the test of second wave. The government was strictly monitoring the use of oxygen at micro level, and we passed that phase successfully. Post-COVID complications that came by, we treated them with COVID follow-up OPD and by counseling our patients very, very accurately. Due to highly contagious nature of the new strain, several of our hospital staff got infected. There was shortage of staff, which was a major challenge, but we passed that as well. As we say, resilience is on our bird, and we will survive this also. The cases now, as you all know, have shown a major decline, and let's hope that the third wave does not come at all. If it comes, I'm sure we will be better prepared next time with less issues and better quality of care to the patients. Thank you.
Yes, sir. We pray that we should not get any third wave. But yes, as we are always resilient, we will be. Now we move on to Dr. Ansari, everyone's favorite, an expert in critical care. We have personally witnessed, sir, your dedication, training in patient management. It could be conducting webinars, research, etc. This pandemic has brought about vivid dynamism of medical treatment protocols and ever-changing SOPs. So please shed some light on your journey through this. The viewers here are clinicians, administrators, and healthcare workers too. So we would like to hear from you.
Thank you, Dr. Ashwini. Thank you for this wonderful opportunity to recount our experience, and it's like walk down the memory lane. And when the whole world was actually hiding, we were actually exposed, and we came out, and by God's grace, last 1.5 years, when we look back, has been very rewarding, fulfilling, and by God's grace, we have stayed safe, and we have come out, I would say, brimming with more confidence and strength. And all of this can only happen because of a concerted team effort. And we at Nanavati Max Hospital Group, we are proud of having fought together shoulder to shoulder as an army. And under the able guidance of our chairman, we were the first ones to come forward. Rather than going on a defensive, we really came out. And I'm very happy when we look back that we took the bull by the horns. When the number of cases were rising, we were also increasing and ramping up our critical care and the COVID ward capacity with all engineering changes, with the dynamic leadership on top. We were able to take the problems of supply chain disruption, getting more, PPE kits, getting the equipments, moved into COVID area and rationing. And at the same time, looking at the manpower. And that was the biggest challenge, because we realized that that was the only entity which was vulnerable to COVID. Rest, everything could sustain or withstand COVID, but not the manpower. And the manpower had to be isolated from their own families. We had to kind of look at their duty schedules, how they should be rested, their cooling periods, their transportation, their stay. and the most important motivation to face an unknown fear, a problem which was raging, which was challenging, treatment was not very clear, and it was evolving, and the disease was unfolding. And I definitely feel very happy looking back that we came back, our minds, our physicians, our microbiologists, our infectious disease consultant, our radiologist, under the able guidance of Dr. Deepak Patkar sir, were able to, improvise ourselves to go through various diagnostic algorithms, therapy planning with whatever we had, and scaling up our therapy regime right from the day when we were using HCQ
Yes.
for our healthcare worker for primary profile access to therapy, moving on to incorporating of remdesivir, then favipiravir, and then moving on to the use of IL-6 inhibitors and immunomodulators. And while we were fighting, the world was also giving the data. So I think in one way, this was the most fulfilling experience, though scary, and it was like an adrenaline rush. Every day we would go there with two worries. One, what happens to our patients? And number two, what happens to our colleagues and our family? And the second fear was always bigger. But I think team effort always wins. And this virus was actually a test of our persistence and perseverance, and also collaboration. So I would say that we were lucky to keep improvising, being flexible, looking at the problems as they came to us. In fact, one of the most innovative solutions that we very early, and we are very, very happy and we can pat our backs, is we thought about the oxygen consumption and the requirement. We thought about having an extra liquid oxygen supply and kind of created it because we were worried that though at this point of time we are not having any oxygen scarcity, but in case if the number of cases increase and the oxygen requirement goes up, because very early we required high flow nasal oxygen, was consuming a lot of oxygen, and the non-invasive ventilators were also a scarcity at that point of time. So I think that one innovation and engineering solutions coming from creating makeshift isolation areas, also kind of creating donning and doffing areas, and very importantly, looking at the rostering of these people. In fact, Ashwini, you had been in the thick of this. You know how difficult it was from the medical superintendent's point of view to look at the rationing and the rotation of those interns, those RMOs from non-medical or surgical areas into the COVID areas. So I think it was a very, very enriching experience. But I hope that these lessons are remembered and we move ahead and be prepared for any eventuality. In fact, it will be a springboard to handle any future catastrophic viral infection or highly infectious respiratory disease, including probably even bioterrorism in the future.
Correct. So the topic today we have chosen is, we didn't want to be completely COVID. We have chosen resilience of healthcare in the current scenario. Because we have seen first wave, then second wave, and now again apprehension of third wave. And in spite of so many treatment protocols, we all stood by. We have given successfully all the treatment protocols. Then came the vaccination that definitely also has its challenges. So you, as a successful clinician, as a director, what advice would you give to the young generation, the clinicians, the residents, the young generation? How would you, help them understand the situation and have a way forward?
So I would just like to draw back and put a quip that resilience. When we talk about resilience,
yes, sir.
Death wins only once, but life wins every day. Every day that you sustain, you save a life, you save actually every day. But yes, death does win. And we all know that that's really the inevitability. But the resilience comes from realizing this fact, but moving ahead and trying to salvage or what they call as die another day. And I think resilience is something which comes from understanding the problem, knowing your fear, and then still moving ahead with all the precautions and the best scientific approach. Now, when you rightly said that resilience will mean different when there was no vaccine, and now in the vaccine era, The resilience comes from vaccinating, having a very thorough approach to that. And number two, separating a hospital into two zones, which we very effectively did in our hospital. Green, red zones, a hospital in a hospital concept. You have another unit where you can kind of either upscale or downscale depending upon the number of your COVID cases, and keep focusing on slowly opening as the numbers come down for the non-COVID work. But the most importantly, non-COVID emergencies in our hospital never suffered. In fact, you know that we had more stroke thrombolysis during the during the COVID times than we used to have before. That's a different issue. That stroke could be a an index disease for COVID, but majority of non-COVID strokes just continued the care in the same fashion. And our neurosurgical department, even oncosurgical and other emergencies, nephrology, they remained open all this while. So I think resilience comes from our effort to continue care in the best evidence and using the best defense.
True. We agree. Thanks, sir, for the wonderful words. It was really enlightening, and hope we meet up again with CIMS Medica for some another great topic. So with this, we now move to another question. Thank you, Ansari sir.
Thank you, Ashwini.
At the start of the pandemic, initially we were all focused, just now as you said, on management of COVID-19, its complications. We were struggling for medicines, like you said just now, cytokine storm. At a society level, we were again focusing on protocols like mask, social distancing, etc. All this was going on, and emerged the most important phase of vaccination. And we were all eagerly awaiting. We all know the vaccination process. Yet we see there are some myths, there are some challenges, some bottlenecks in the conduction of the entire vaccination drive. And now when we were settling with the vaccination, now again, sir, we hear this third wave, the Delta virus, the mutants, and again, it's indeed causing apprehension, not only in the society, but we as healthcare workers. How do we gear up? So how do you like to now conglomerate all the above factors in the direction of way forward? So we all viewers are eager to listen to this, sir.
Absolutely. And I'm quite clear about that. If there are few things that will help us tide over the crisis, present or future, it will be mask, and it will be vaccine. If somebody asks me, sir, which is the best vaccine? My answer is mask. That is the best vaccine. But yes, what we should do, I agree that there is some amount of vaccine hesitancy. There are myths and misconceptions. And in society, whenever a new thing is rolled in, there are always people who want to put brakes in a moving wheel. So they spread rumors. Oh, vaccine contains this. Vaccine does not contain this. Vaccine will not be effective against Delta. We really don't know whether the vaccine will be effective against its variants, yes or no. Only time will tell us. But please remember, all this belong to finally the same family of the coronavirus. So what happens is that once a vaccine is given, the T cells in your body get primed. And then there is something called as a trained immunity that comes up from these T cells. So therefore, it's not that you will not get corona. We have never said that. You may still get corona even after vaccination. But the magnitude of that corona will be much less. There are less chances that you will need hospitalization. There are lesser chances that you will need ICU and oxygen, and there are least chances that you will succumb. So therefore, what does the vaccine do? The vaccine increases the individual resistance to fight COVID. And in the community, it contributes to the cause of herd immunity. And therefore, it is mandatory that whichever vaccine is closer to your area of either work or home, you must go ahead and take the vaccine as your national duty.
Great, sir. So one final take home message
Well, Corona is not going to go away by the flick of your fingers. It's going to linger. It has a very, very thick tail. So the prudence lies in protecting ourselves. And therefore, the only task that we have is to say mask, mask, and mask. So please wear the masks and protect
Yes, sir.
yourself. Thank you.
Thank you. Thank you, sir, for your valuable time. We know you're so busy and yet you took the valuable time in guiding all of us. We really thank Dr. Sanjay Ok, sir. Please continue your great work and keep on enlightening us. On this short note, I take leave of Dr. Sanjay Ok, sir.
I take this occurrence to thank the entire committee for representing the valuable views. I must mark a proficient sense of gratefulness to all our esteemed panelists for sharing with us some of the finest healthcare experiences and management practices. All the participants of this meeting were really inspired by the highly sparkling words of our esteemed panelists. I want to extend my generous thanks to the august audience who have taken the time to be engaged with us, for viewing this excellent panel discussion, for extending their support and cooperation. We would not have had a successful program without your support. No event can happen without the provision of a vast network of very well coordinated team and far-sighted memberness. Hence, I would take this opportunity to thank the entire team of CIMS Medica. Thank you all.
Wow, that was such an interesting panel discussion. We would like to thank our panelists, Dr. Sanjay Ok, Dr. Deepak Patkar, and Dr. Abdul Ansari, and our moderator, Dr. Ashwini Jogare, for extracting valuable insights from our fellow panelists. Ladies and gentlemen, CIMS Healthcare Excellence Awards intends to felicitate the achievers in healthcare and pharmaceutical industry to encourage healthy competition, resulting in better delivery of healthcare services. The award ceremony presents an opportunity to be in the company of reputed consultants, heads of leading healthcare institutions, healthcare business investors, and senior management of leading pharmaceutical companies, all under one roof. Ladies and gentlemen, we are very honored to have some very special dignitaries joining us here this evening. We have a chief guest and guest of honor joining us. Ladies and gentlemen, please help me in welcoming Shri Satyendar Jain, Honourable Minister of Home and Health Welfare, Public Work Department Power, Government of Delhi. He is a cabinet minister in the Government of Delhi. He is currently in his second term as Delhi Health Minister, having previously served as Health and Industries Minister. Welcome to you, sir.
मैं सिम्स मेडिका को हेल्थ केयर एक्सीलेंस अवार्ड्स के 9वें संस्करण पर बधाई देता हूं। सिम्स मेडिका दुनिया भर में जो दवाइयों के अंदर नई रिसर्च हो रही है, नई चीज़ें आ रही हैं, उनको और हेल्थ प्रोफेशनल्स के बीच में ब्रिज का काम करता है, उनको इन्फॉर्मेशन प्रदान करने के लिए सहायता प्रदान करता है। अभी कोविड महामारी के दौरान दवाइयों की कितनी मात्रा देनी है, कैसे देनी है, उससे पता लगा कि दवाइयाँ जीवन दान भी दे सकती हैं और उसकी वजह से जीवन खतरे में भी पड़ सकता है। और इस सारी इन्फॉर्मेशन को सिम्स मेडिका ने हेल्थ प्रोफेशनल्स के साथ बहुत ही अच्छी तरीके से शेयर किया। इस अवसर पर मैं सभी विजेताओं को और फ्रंटलाइन वर्कर्स को बहुत बहुत बधाई देता हूं, जिन्होंने कोरोना के खिलाफ हो रहे इस युद्ध के अंदर अपनी पूरी जान जोखिम में डालकर दिनों रात मेहनत की और लाखों लोगों का जीवन बचाया। हमारे डॉक्टर्स, पैरामेडिक्स, फार्मासिस्ट, शोधकर्ता, जितने भी रिसर्चर्स हैं, सभी बहुत बधाई के पात्र हैं, जिन्होंने इस मुश्किल समय के अंदर काम करके लोगों का जीवन बचाने में सहयोग किया। दिल्ली सरकार ने हमेशा हेल्थ केयर को प्राथमिकता दी है, चाहे वो मोहल्ला क्लिनिक्स हों या हॉस्पिटल्स हों। हेल्थ केयर के अंदर बहुत बड़े स्केल पर इन्वेस्टमेंट की और लोगों की जान बचाने के लिए, लोगों को हेल्थ केयर घर के पास मिल सके, हर तरह की सुविधाएं मिल सके, इसके ऊपर दिल्ली सरकार ने बहुत काम किया है। और दिल्ली सरकार ने अपने बजट का बहुत बड़ा हिस्सा हेल्थ केयर के ऊपर पिछले कई सालों से खर्च किया है। एक स्वस्थ नागरिक ही देश को आगे बढ़ाने में मदद कर सकता है। मैं आशा करता हूं कि सभी लोग स्वास्थ्य के क्षेत्र में अपना ध्यान रखेंगे और एक बार फिर से सिम्स मेडिका को हेल्थ केयर एक्सीलेंस अवार्ड्स के लिए मैं बधाई देता हूं। धन्यवाद। जय हिंद।
Ladies and gentlemen, please help me in welcoming Shri Rajesh Tope, Honourable Minister of Public Health and Family Welfare, Government of Maharashtra. Ladies and gentlemen, please put your hands together and help me in welcoming Dr. Girdhar J Gyani. Dr. Girdhar J Gyani is currently the Director General of the Association of Healthcare Providers in India, which is also known as AHPI. Prior to this, Dr. Gyani was Secretary General of Quality Council of India. Warm welcome to you, sir.
I am happy to learn that CIMS Medica is organizing 9th edition of Healthcare Excellence Awards. The way the philosophy of CIMS I have seen is empowering healthcare communities. I must add here that these are very difficult times and we need to encourage, motivate and inspire the healthcare community, healthcare workers, doctors, nurses as much as we can. I convey my best wishes to CIMS on organizing these awards function. Thank you very much.
Ladies and gentlemen, the moment that we all have been waiting for has finally arrived. Yes, you guessed it right. It's time to begin with the CIMS Healthcare Excellence Awards 2021. Also, let me tell you that the order of categories have nothing to do with the importance of the category. Each and every category we have tonight is equally important. Alright, so we'll start with the first category of the award, which is Innovative Marketing Strategy for Patient Care. And the winner is...
I would like to thank jury members for recognizing our efforts and judging us with innovative marketing strategy for patient care. I would also like to thank and acknowledge support and contribution of my colleagues and seniors who have been a part of this marketing, communication and initiatives. We are truly honored to receive it. This award will motivate us to further build on marketing initiatives which will enrich and add value to the life of healthcare service providers and patients. I also take this opportunity to thank organizer CIMS Medica for successfully hosting this virtual Healthcare Excellence Award. Thank you once again.
The next category is Emerging Brand of the Year, Cardiac Care, and the winner is
Yeah, we are from AMCure very grateful for this award given for Emerging Brand of the Year from CIMS Healthcare Excellence. So Exafib is now #1 brand in rivaroxaban Indian generic from 6 months. We have achieved this only because of the strategic planning and execution. So it is really difficult for me to express my gratefulness for having every one of you here tonight, and to be selected for this honor for this part is a great privilege. So thank you once again. Thank you so much.
Moving on to our next category, which is Emerging Brand of the Year, Diabetes, and the winner is
Yes, we did it. I'm very, very happy and excited to hear that brand Besaglar win Emerging Brand of the Year award from CIMS. It's good to know that the entire industry is recognizing our effort. And I would like to thank all the key stakeholders, especially the entire sales team, for their contribution towards the success of this brand. And it's really a moment of pride for us, and good to know that whatever we are doing is impacting diabetic patient life. Thanks, CIMS, for this recognition.
It's a great honor and pride to hear the great news that Besaglar as a brand have won the prestigious CIMS Emerging Brand of the Year, and that too in the diabetic segment. And I would like to dedicate this award to all the team members who have contributed in changing the diabetic patient's lifestyle. And it echoes with CIPLA's vision of caring for life. And also I would like to thank CIMS for this recognition as the Emerging Brand of the Year for Besaglar. Thank you.
Moving on to our next category, which is Nutrition Care Portfolio, and the winner is Many congratulations to all the winners. Ladies and gentlemen, CIMS Medica has 2 special recognition for this evening. The first one is Inspiring Healthcare Personality of the Year. Let me tell you, he is an IPS officer, the first Indian to finish RAW, world's first IG rank Ironman and Ultraman, who has successfully completed the Ironman Triathlon, widely considered one of the most difficult one-day sporting events in the world. Wow! The triathlon, participants are required to complete a 3.8 kilometer swim, a 180 kilometer long bicycle ride, and a 42.2 kilometer run, all within a set time frame of 16 to 17 hours, and made it to the World Book of Records. That's so amazing. Ladies and gentlemen, let's welcome the recipient of this special category.
I take this opportunity to congratulate all the winners, top hospitals, doctors, pharma companies, and police personnel all across India. And also the frontline workers and all healthcare professionals for giving the best during this COVID times. Thank you for saving lives of millions. Thank you CIMS Medica team for awarding me this prestigious award. Stay fit, stay healthy. Take care. Jai Hind.
Ladies and gentlemen, the next recognition is Celebrity Fitness Icon of the Year 2021. The winner of this category is the Diva of Bollywood. We all have appreciated her work in a lot of films. She was crowned Miss Diva Universe in 2015 and also represented India in Miss Universe 2015 pageant. Fitness is her way of life. Let's see who the winner is.
I'd like to thank CIMS Medica for the Healthcare Excellence Awards national level for awarding me with Celebrity Fitness Icon of the Year 2021. And I truly feel that fitness is a way of life for me, and I'm just extremely thankful to the entire jury and to CIMS Medica, to Mr. Alok as well, for honoring me with such an amazing award, and I'd like to congratulate all the winners. So thank you so much, and I know we're going through with this pandemic, but we all have to unite together and take care of our nation as well. Thank you.
Ladies and gentlemen, let's move on with our healthcare awards. The next category for award is Most Trusted Brand in Stress Management, and the award winner is
Hello, good evening everyone. I am Suman Mukherjee from Dabur India Limited. First of all, a big thanks to CIMS Medica for recognizing our brand StressCom as most trusted brand in stress management, the Healthcare Excellence Award 2021. Stress is a big problem in today's context. As per the recent statistics, 89% of Indian millennials suffer from stress, which is even higher than the global standard. And post-pandemic, as per the Google data, stress is one of the highly searched keywords in the Google, and stress affected almost everyone in the society post-pandemic. StressCom is a product developed by Dabur Research and Development Center. With a very specialized lipid-based technology, StressCom ensures optimum therapeutic efficacy compared to other marketed herbal or Ayurvedic brands. And StressCom is being widely accepted by physicians across the country and helped millions of patients to get relief from their stress or related disorders. So thank you very much once again, CIMS Medica, for recognizing 100% Ayurvedic or herbal brand StressCom as a most trusted brand in stress management. And hopefully going forward, more and more patients will get benefited from StressCom therapy.
The next category is Hospital of the Year in Patient Care, and the winner is
Hello everyone, I am Dr. Deepak Patkar, Director of Medical Services and Head of Imaging Department at Nanavati Max Super Specialty Hospital. We are honored to receive this important award. It is a true testament to the courage and dedication of our doctors, nurses and support staff who worked tirelessly to ensure seamless patient care despite numerous challenges. I am thankful to the judges and management of CIMS Medica Private Limited and assure them that we shall continue on this path of building a healthier tomorrow. Thank you.
The next category is Hospital with Highest Standard in Cardiac Care, and the winner is The next category is Neuropsychiatric Pharma Company of the Year, and the award goes to
Good evening, everyone. First and foremost, I would like to thank all the COVID warriors for their immense sacrifice and contribution towards the nation in this difficult time. We at Lifecare Neuro Product Limited are truly honored to receive this prestigious award from the CIMS Medica. We continuously strive to uphold our motto of caring and curing, as we have done since 1994. On behalf of our team at Lifecare, I congratulate all the participants and our jury members, entire CIMS team who have been a part of this wonderful event.
The next category is Promising Diabetic Company of the Year, and the winner is
Thank you, CIMS Medica. I humbly accept this award on behalf of the entire Lloyd family and Mr. Narayan Vikram Rao. This achievement is a reflection of our great determination of each and every member of the Lloyd family. We have come a long way, and we understand that such awards puts across increased responsibility on us to continue working ahead. We have that confidence and that we will cross this journey successfully and faster. My heartiest congratulations once again to all the Lloyd family team members. Please share this moment of happiness and let us work tirelessly to take Lloyd to the right place where it deserves. Namaste.
Ladies and gentlemen, we have reached halfway through. Let's see which is the next category for awards. It is Most Engaging Scientific Platform from Pharma Company, and let's see who the winner is.
We are from AHPI very delighted to receive Most Engaging Scientific Platform Award. Our organization objective is always to provide a great scientific platform to all our doctors. So through this no thrombosis platform, we have reached thousands of doctors. So today we are very happy that our no thrombosis, a high scientific engagement platform focused to discuss on thrombosis, is recognized by CIMS Healthcare Excellence Platform. We have built the brand through the support of science, and we are always believers of that. So from behalf of AHPI, we want to say thank you so much for this award. Thank you.
Our next category of award is Hospital of the Year, Best Healthcare Delivery. And the winner is...
Thank you for the CIMS Medica for organizing such a national level event and recognizing and motivating all the good work that has been done by the healthcare providers across India. And it's a pleasure, and I'm really feeling proud and wonderful feeling right now to receive this award for the Hospital of the Year, Best Healthcare Delivery for the CIMS Medica Excellence of Healthcare Awards 2021. And I would like to congratulate and applaud for each and every healthcare workers, the frontline workers who have really worked very hard and exemplary work of delivery in this era of COVID. And I would certainly wish all the very best to everyone, and stay safe and stay healthy. Thank you.
The next category is Wellness Brand of the Year, and the winner is...
Hi everyone, I'm Ananta from GSK Consumer Healthcare. Thanks CIMS Medica for recognizing Ottering Breathe Clean as Wellness Brand of the Year. Last 8 months, we have tried to create awareness about one of the most important pillars of personal hygiene, that is nasal washing. Nasal hygiene is something that no one is taking care of right now. But with Ottering Breathe Clean, we want people to adopt a new habit of nasal washing to get rid of pollutants, allergens, and even bacteria and viruses from our nasal passages and keep it healthy. And with Ottering Breathe Clean, we really aim to do so. Thanks again, everyone.
The next category is Innovation in Pharma Manufacturing, and the winner is...
Thank you very much, CIMS, for recognizing our work in novel drug delivery system in a pharmaceutical manufacturing. Really, it's a great honor for me to get this award for innovation in pharmaceutical manufacturing. Thank you very much.
Ladies and gentlemen, next 5 awards to go. And the next category is Best Emerging Company in Neuropsychiatric Segment, and the winner is...
Good evening, everyone. This is Gaurav Agarwal, one of the director of Grip Pharmaceutical Private Limited. I truly honored to receive this prestigious award from CIMS Medica. Grip Pharma is dedicated to the neuropsychiatry segment from last 3 years. Our motto is to provide affordable medicine to the common people. First of all, I would like to thank all the doctors for their dedication and hard work during the COVID pandemic. And I also want to thank the jury members and CIMS team for their consideration and conducting this wonderful event. Thank you so much.
The next category is Pharma Excellence in Respiratory Portfolio, and the winner is...
Hi, this is Rahul here. Thank you so much for this gesture and recognizing Seroflow. Seroflow has been a catalyst when you look at the revolution that has happened across the asthma and COPD market in India. And we've been doing this for the last 20 years. Just last year, we've celebrated the 20th anniversary of Seroflow, and it was a grand success, and we made so many milestones again to ensure that Seroflow is the key and the largest brand in the Indian pharmaceutical market in the space of OAD. Thank you so much, and we will continue to do best with our brand Seroflow.
The next category is Best Manufacturer in Soft Gel and Nutra. And let's see who the winner is.
Yeah, good evening everyone, and it's been an honor to be here. We are thankful towards CIMS and from our whole Emory Softcare groups to receiving this award for the Best Manufacturer in Soft Gelatin category in 2021. We also congratulate to all the other winners as well as the jury member, and thanks a lot to CIMS again. And we also thanks a lot to all the first-time workers, those who are working in this condition of pandemic, all doctors, pharmacists and every first-time worker. Thanks a lot.
The next category is Emerging Pharma Company of the Year, and the winner is
Good evening, everyone. First and foremost, I would like to thank all our COVID warriors for their immense sacrifice and contribution in these difficult times. We at LifeGenix are truly honored to receive this prestigious award from CIMS Medica. As part of Team LifeCare, it has been our motto to provide world-class formulations at affordable rates. We shall continue to strive for excellence as we have done since 1994. On behalf of our team at LifeGenix, I would congratulate all the participants and thank our esteemed jury and the entire CIMS team for the memorable event. Take care and stay safe.
Ladies and gentlemen, we have reached the final award, which is last but not the least. The category is Social Responsible Brand of the Year, and the winner is
Hello everyone. I'd like to thank the jury of CIMS Medica for the award. First and foremost, my hearty thanks to the doctors for being a part of this social initiative of Girdhar and help us win this award. I'd like to dedicate this award to my sales team for the support for this campaign. Special thanks to my fellow PMT members and my superiors, Subramani sir, Josefa sir and Vikram sir for their continuous motivation and blessings. Thank you all again.
wow. Many congratulations to all the winners. Really, heartiest congratulations to each and every one of you. With this, we have come to the end of the award ceremony. Ladies and gentlemen, CIMS Medica would like to thank our chief guests, guests of honor, respected speakers, delegates and attendees for making this event a huge success. CIMS Medica would also like to thank all our media partners and association partners. Thank you all once again for being present for the CIMS Healthcare Excellence Award 2021. Kindly take care, stay home, stay safe and be connected. Thank you.